Hello and welcome. Tonight we're speaking about the Seva Foundation. With me is Jack Blanks, the director of Seva. Jack, thanks for coming.
Thank you, Tom. It's a pleasure to be here.
All right. Well, I thought we might start by talking about the founding of Seva.
Sure. It's actually a great story, and I really enjoyed telling it. Back in 1978, nearly 35 years ago, there's Dr. Larry Brilliant, who was working in the eradication of the smallpox in India. Basically, when they completed that enormous task, he and a group of friends were sort of looking for the next thing to do. So Larry called together some of his colleagues, and long story short, they decided to take on the issue of world blindness. So he pulled together other scientists and doctors, but he also, as a person who had been quite an activist through the 60s and 70s, had a very eclectic Rolodex. So he also invited Ram Dass, for example, to be a founder. Wavy Gravy, who's an icon right here in Berkeley. He ended up putting together this very interesting group that was grounded not only in science but in spiritualism and activism, and they decided their cause would be to eliminate needless blindness in the world.
And you named it Seva.
Named it Seva. Seva is a Sanskrit word and it means selfless service. And I think probably Ram Dass had something to do with that name, but the name stuck and we've been Seva ever since.
And those founders are still very active.
They are indeed. In fact, Wavy Gravy is still an active board member. He was in the office today and he's sort of board member for life. We have a board like most boards where people get elected, but Wavy is board member for life pretty much. And Ram Dass is still an honorary board member. He lives in Hawaii now, so he's not close enough to come and go easily. Larry is still very involved, although he's not on the board. But many of our advisors are still around from those early days.
Larry became the CEO of Google for a time.
Well, he became the head of the Google Foundation.
Oh, that's right.
A few years ago. And then he went on to become the president of the Skoll Global Threats Fund, which is where he works today. Very active in TED and many other things, still very much an activist and a great supporter of Seva to this day.
So now you're focused on the 90% of the people who are blind in the world are in what we call developing countries.
Yes.
Particularly Tibet, Nepal, Cambodia. You have facilities in all those locations.
We do, and in many other countries where we may not have our own office, but we'll have partner institutions that we work closely with. We started, right after the founding, Dr. Brilliant met a guy named Dr. Venkataswamy who created the Aravind eye care system in India. At that time it was a tiny little clinic with 9 beds, and Dr. V, as we call him, came on the board, and we consider him a founder as well. So we got our start in India trying to provide support to Dr. Venkataswamy, who came up with this concept that you need to do high volume eye care and high quality eye care and serve the poor essentially free of charge, but do such a good job that those who can afford to pay something will also come to your hospital. And the paying portion then cross-subsidizes the non-paying portion. And the formula has worked really beautifully, not only in the Aravind context. They're now the largest eye care system in the world, from 9 beds. Founded in 1976, they now provide eye care services to over 2 million people a year.
That's incredible.
And they do over 200,000 surgeries a year.
Cataract surgeries?
Cataract, across the board. I mean, they won the Gates Foundation Award a couple of years ago. They won the Hilton Humanitarian Award a couple of years ago. So Dr. Venkataswamy sort of introduced us, or we helped each other in those early days to develop this model whereby those who can pay do, but no one is ever turned away for lack of ability to pay.
So about a third pay for the 2/3 that count?
In most countries where we work, a third will pay something. It may be $1, or it may be $20. There's a certain dignity in being able to pay something for your care, but there are some folks who absolutely can't. And it works very well. Across all the countries where we work on some variation of that model, whereby those who can't afford to pay something do. Last year, Seva, now again, we're much smaller than the Aravind Eye Care System, and we work in many countries and focus a lot on training and helping across the board with management and many other barriers to being a good eye organization or a good eye hospital. But we have facilitated about 86,000 surgeries through funding from our foundation, and about 1 million people were served through the programs that we run or support.
That's in 1 year?
That's 1 year, yeah, that's in 1 year's.
Yeah. So during the course of your life, how many is that?
Somewhere over 3 million. We say that over 3 million people have received sight restoring surgery as a direct result of funding that has gone out from Seva to our own programs or perhaps directly to a partner program. We have offices in Nepal, Cambodia, and Tibet with our own staff. We still partner with local organizations, but in places like India, Pakistan, Egypt, Uganda, Ethiopia, Guatemala, Paraguay, we've identified partners, and we actually operate directly with those partners and don't go to the expense of creating an office and having to field our own staff. We essentially partner up, and we figure out what we can do to fill gaps and strengthen the capacity of those organizations to deliver eye care.
How big is your actual operating organization?
You mean in terms of finance? Or in terms of our staff? We have 16 people in headquarters here in Berkeley. We're located on 5th Street, down near the Berkeley Shops area. We have another 12 staff, permanent staff overseas. Our budget fluctuates between $3 to $5 million in a given year. We're an unendowed foundation, so we have to go out and raise our money every single year.
You have some great concerts.
Yes, we do some innovative fundraising, I will say for sure. More than 50% of our funding comes from individual donors, just like you and me, people that believe in our cause and write us a check every year. But we have a long history with the music industry. Wavy, through his connections with the Grateful Dead, brought them on board very early. Bobby Weir is on our board, actually. Yeah. He's an honorary board member, but the Grateful Dead played a major role in fundraising in the early years. Whenever Seva needed additional money for their programs, the Dead would just go out and perform. That spawned a plethora of relations with the musical industry. Bonnie Raitt, Jackson Browne, Elvis Costello, Ani DeFranco, on and on. Joan Baez have done concerts for us over the years, and we still do 2 or 3 concerts every year to generate awareness of the problem. There are 39 million people in the world who are blind, another 275 million who are seriously visually impaired. So concerts are a great way to spread the word that there's a big job for us to do out there and also raise money.
So the job remains large. There's a lot more to do.
Yes, very much. There's an organization, an umbrella organization called Vision 2020, and there's several dozen of us eye organizations in the world, and we try to work under that umbrella to coordinate our activities around the world. And our common goal is to eliminate unnecessary blindness. And like you say, 90% of it is in developing countries. 80% of the folks who are blind in developing countries don't need to be. I mean, they're blind from preventable or curable conditions. Cataract.
How did they become that way?
Well, cataract is the single largest cause of blindness, and that's simply an opacification of the natural lens in your eye. And that can be caused by age, sometimes by injury. There's congenital cataract in young people. But that causes about 50% of that 80% of curable, preventable blindness.
So a lot of that population is in their 50s?
Yes,
60s?
A lot of them are in, although in the U.S., we tend to perhaps age more slowly in some ways. So cataract is a disease of people 50 and over. It's a condition of 50 and over, and maybe even later. In many developing countries like India and Tibet and Nepal, the onset of cataract is much earlier. And there's not a clear evidence exactly why. There's a lot of studies going on, but I think people age more quickly. They're exposed to more UV. They're at much higher altitudes in in some places, but the result is a much higher incidence and prevalence of cataract at earlier ages. The highest known incident of cataract in the world is in a country like Tibet. So
I would imagine they're exposed to a lot of UV.
yes.
You see the average Tibetan and their skin is
UV
quite weather-beaten.
Exactly. And there are other eye diseases that have and eye conditions that are directly associated with exposure. The thing about cataract, though, is it's a 15-minute operation. And the average cost to our program, where we do high volume and high quality procedures, is about $50. So, you're looking at 18 million people in the world who's, for lack of a simple operation or access to basic eye care, are blind that don't need to be blind. The rest of that 39 million, you could have, trachoma, you can have, glaucoma, macular degeneration. There's a whole range of disease, but many of those are also treatable.
In the same way?
Well, perhaps a more complex procedure or a longer procedure. The beauty of cataract is you remove the cataract, you implant an artificial lens.
Yes.
The next day, when the eye patch comes off, the person can see, and you're done. And it will follow up, obviously. You want to make sure there's no post-operative infection. Someone with glaucoma has to basically take medication for the rest of their life, but it can be controlled, and the progress of the disease can be stopped, essentially, by getting somebody under treatment, and it's not terribly expensive, as long as people have access to the medication.
Now, you also work with indigenous peoples here in the U.S.
Yes.
You have a diabetes talking circle.
One of the tools that was developed during the course of our work with Native American populations. Early on, probably 3 years after our founding, Seva sent a delegation. It actually was a caravan of buses to the Black Hills in South Dakota, and there they met with some Native American folks, and because of this orientation towards service, I mean, we're not limited only to working in the field of blindness prevention. They met with a group of Native Americans, this group from Seva, and were convinced that in our own country we have some very serious health disparities, and so that launched an initiative to work with Native American groups at the community level around a plethora of health issues. Over the years, that has focused a little more and more in the area of chronic disease, diabetes, obesity, heart disease, that sort of things that can be controlled through or improved through diet and education and exercise and other types of interventions. So yes, we have been working very actively with Native American communities across many of the states in the United States in this chronic disease arena.
Which tribes?
Well, we've worked in Alaska with the Inuit, in South Dakota with the Lakota. Here in Oakland, the second largest diaspora of urban-based Native Americans in the United States is in Oakland, after Chicago. Over 100,000 people with Native American heritage live in the Oakland area. They came here in the 50s and 60s when the federal government had a work program that essentially moved men, initially, off of the reservations into the Oakland area for work. And then their families followed, and eventually that created this sort of large group from many, many different reservations and Native American groups around the U.S. And then with good times and bad, that created a large group of Native Americans, some doing quite well economically, but others who are in need of help. So we work very closely with the Native American community right in the Bay Area.
And how does the talking circle work?
Talking circles essentially was taking a traditional Native American practice where in a circle, people would pass a pipe or some other symbol that allows that person to speak and not be interrupted. And it's a very old and sort of treasured and wise way of allowing people to speak their mind without fear of being interrupted or criticized in any way.
How many people?
I think it varies.
20.
But yeah, with the diabetes talking circle, it would be however many people come in that particular evening. But there's a certain stigma that is sometimes associated with having diabetes, or people not wanting to speak out, or for fear. And by creating a way for people to sit together in a circle in a traditional Native American way, and to take the pipe or the symbol or whatever it is that indicates, or the stick, whatever it might be, and know that they can speak their mind and without being criticized and without being interrupted, became a great way for us to have people talk about their disease or disease in their family or the impact on their family, and for our health educators to also talk back with them about what can be done to address the disease.
How did you come about doing it this way?
For many years, we had a Lakota woman who was on our staff. Her name is Lorelei Decora, fantastic health educator who from South Dakota, and she was the one who came up with this idea of using this traditional way of expressing yourself in a group dynamic, and adapted it for diabetes education and for sharing amongst people, so that people get over their fear or the stigma that of this particular condition, and then learn from one another. Peer education. And we still do it to this day. And we even have a webinar that's now available where if somebody can't go and actually run a talking circle, a local health educator can see how this works online. And it's been accepted by the CDC as a best practice.
Good. It seems like you have a technique of finding very simple technologies that work and spreading them.
Indeed, in terms of education and in terms of the actual direct services that we deliver. In terms of the site, it has to be the highest quality. I mean, that's the key, but also trying to work in very high volume. That way we can develop an affordable eye care that serves the entire community. Without that paying portion, it's difficult to have a sustainable program. In the Native American context, it's more adapting tools and beliefs and mores that make sense, to do culturally appropriate approach. And we've always had Native American folk on our staff as well. Our Native American program is actually headed by, a Native American person, and our interns and staff are very often Native American as well in headquarters.
So is the main challenge for you now ramping up? I mean, you've ramped up to a degree, and you're serving a lot of people already, but still, with so many more out there, I suppose that is the challenge for you.
It is indeed. There's such a large backlog of people who are blind for one reason or another in developing countries, that even though we've made a tremendous amount of progress and we've reached over 3 million people, which is pretty impressive for a small foundation that operates on a budget of less than $5 million a year, there's so much more to be done, and so we're constantly trying to grow and partner. And the sustainability approach that we take really focuses on enhancing the capacity of the partners that we select, both with the Native American work that we do. We don't work independently. We find a partner group, and we try to enhance their capacity, since they're going to be there, hopefully forever. And
I wonder how much it costs to find a new partner. Have you ever figured that out?
I don't know if we've looked at it.
Would be a great big gift card. You have these gift cards, and we should talk about your gift cards.
Yeah, adopt a partner.
Adopt a partner.
Yeah, or a hospital, for that matter. I mean, we have a program right now that has been recognized by the Clinton Global Initiative, which is called So 1 Million Eyes Can See Again, and the whole concept is for us to replicate this model in site that we use, whereby a certain portion pay and the rest, are served at a highly subsidized rate or free of charge. We're trying to get 100 hospitals in developing countries around the world capacitated to really use this model and scale it up. So you, in essence, could adopt a hospital, because it's amazing how little it actually takes.
$10,000, 15?
Probably more like $50,000 over a few years, because there's a lot of training involved, there's equipment involved, sometimes their infrastructure has to be upgraded. But when you think about it, you may have a hospital that's doing 5,000 surgeries a year that could easily do 15,000 surgeries if they could just get over a certain threshold, technically, infrastructure-wise, training-wise. So we try to facilitate that package that moves them over that level. And so you get this explosion of, big expansion of service for, not a lot of investment. So our goal is to do that right now across 100 smaller hospitals or eye departments in developing countries, and be able to enable them to do 1 million more cataract surgeries than they are collectively doing now, every year. And same with the SITE program, capacitate local organizations to do more and better what they're already trying to do by trying to fill in the gaps.
So you have a gift card program. Someone can give $100 and give SITE to someone?
Right, we do. It's called Gift of Service, and it's an alternative giving program. We have a beautiful little catalog and a whole array of gifts in this catalog. And essentially, to give you an example, instead of giving Grandpa a shirt and a tie for Christmas, you can give $50, which will enable us to do an eye operation for someone in a developing country, restore their sight. And Grandpa receives a beautiful card from us saying that, granddaughter Jill has given him this as her gift for whatever holiday or season or birthday. It's a wonderful way to raise money, and your $50 is still tax exempt. So it's still a charitable contribution to a 501c3 organization.
That's clever.
And it's a
gift, but it's not...
so it's a gift of service.
Yes, gift of service.
And, how many people would love to have, that sort of gift be given to them?
Yes.
Instead of something that's, they may never use or may never wear, and somebody gets helped. And
another material object.
And we generated probably about a quarter of our total revenue through that mechanism of people giving these type of gifts. And you can sponsor an entire eye camp, where we may do 300 or 400 or 500 surgeries. You can sponsor a single
How much is that?
operation. It's $15,000.
Yeah.
And the average eye camp, this is a mobile eye camp where we actually go into a remote community where they don't have access to an eye hospital, and we'll do an actual surgical eye camp where we may do 300-400 surgeries and actually see several thousand patients with general eye care. We have a beautiful 7-minute video that actually depicts what actually goes on, and I'll share that with you sometime.
Good.
So there's probably 30 gifts in the catalog. I don't know how many exactly we have this year. Some are Native American focused, and others are focused on our SITE program.
$50, $25?
Anything from $25, and if you just want to pack of cards, even less than that, up to $15,000, $20,000. I mean, you could build a small eye hospital if you really were so moved, if you wanted to give a large enough gift. But they're mostly much more in the affordable range, $25, $50, $100, $200 for a variety of things. Gender specific as well, for people who are interested in helping women who, interestingly enough, I should say, 2/3, almost 3/4, but between 2/3 and 3/4 of the blind people in the world are women. And that's because they have less access to care. And that's because they're less mobile, and in many cultures, if there's enough money in the family for someone to receive eye care, a male will get it before a female will. So we found that by taking eye care right into the village, you really can erase a big part of that barrier. And in most of our programs, more than 50% of our patients are women, because we've focused on this gender inequity for a long time, and we've been able to work our way through it. But it's so we have gifts in our catalog that are focused towards assuring that women also receive sight care, or in Native American.
Volunteers, stateside.
We have wonderful volunteers, and
Do you want more? Or
Sure, we have. You can go right to our website, because we are clinically focused for the most part on the eye side of the equation. It's hard for us to accept generalist volunteers. It's a little hard to place generalist volunteers, but certainly ophthalmologists, eye technicians, ophthalmic nurses, really are instrumental in helping us train. We don't need them to go and deliver the service so much of the actual eye surgery because our focus is on training. But we do need them to help us train Tibetan ophthalmologists and Nepali ophthalmologists, especially in the subspecialty areas. Cataract, they've got it down. But if you're a retina specialist, or if you're a neuro-ophthalmologist, or if you're a pediatric ophthalmologist, we still actively look for folks who can bring those services and who can work well in a different culture.
Perhaps do a year of service. It's not a complete career change, but could you use someone for a
that
year
has
or two?
happened on rare occasions. Most volunteers go for 2 or 3 weeks, and they actually train. They go into an environment where we're ready for them when they arrive, and they work with local residents or local doctors.
Oh, so it could be a little sabbatical of a month.
In a very intense way.
Interesting.
And a byproduct of that is a lot of surgery gets done, but really the goal is that they're there to train.
Right.
It's much more sustainable if we can train local people. The cataract surgeons in our programs abroad are actually much faster and do much higher volume than most surgeons do in the States. So they actually, in some ways, are better in that sense. But cataract is, a pretty straightforward, simple operation unless it's a complicated case. But in the subspecialty areas, we recruit volunteers all the time.
Good. Well, Jack, we're out of time. I want to thank you for coming here and talking to us about Seva.
Yeah, it's
been great to learn about it.
Thank you so much for having me.
And thank you for your work.
My pleasure.
Good. And thank you for watching. Good night.